Hello, I'm Dr. Obey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we're here again, and I want to emphasize sharing and caring. Listen, guys, if you know a neighbor, if you have a grandma or a mom or pop that needs to go to the doctor, let's care about each other. Take them to the doctor. We need to check up on each other. Make sure that they're taking their medicine. Make sure if they need help going shopping or going out to the park to enjoy themselves for the day. Let's share and care. Alrighty. And remember, Facebook. We're on Facebook. We're on Twitter. We're on Instagram. Check us out. That's Obey Your Doctor. And also, our website, obeyyourdoctor.com. Come on and check us out because it's really good. A lot of health and educational material. It's all good. Come share and care. All right, our Let's Talk segment. Today, I would like to talk about health, wellness, nutrition, and fitness. It's so important. I truly believe that fitness and health and wellness all comes together in a package when you are the appropriate weight for your height. That is, whatever your height is, there's amount that you should weigh. And if you weigh that amount, it means that there's a possibility that you have that longevity, that healthiness. And it's what you eat and how you eat it. So let's go through a few things. So, as I stated, let's be a healthy weight. That's number one. Number two, be active. At least 150 minutes of moderate activity, 75 minutes of vigorous activity, and this should occur at least over a week's time or once a week. If you can do more, that's even great. Eat healthy, eat a healthy diet. Lots of plants and vegetables. They are good. They have a lot of macronutrients as well as micronutrients, things like potassium and chloride and magnesium, those things that our cells need to function appropriately, okay? And that big one, don't smoke cigarettes. If you smoke, stop it. If you drink too much, cut it back. I'm not going to say stop drinking. We all like a little wine with our dinner every once in a while, but you should decrease the amount that you take in, all right? So let's be healthy as far as our diet is concerned, and that's most important because guess what? Certain cancers may be increased if we're obese or if we're really overweight. So let's be mindful of our weight. Eat healthy, let's decrease our weight, let's be healthy out there, guys. All right. Our topic tonight, it's a very interesting topic. And I'm glad to have the physician that we have here tonight because it's an interesting topic because and I'll give you the name, it's uterine fibroid embolization. And it's a way that we can treat fibroids without surgery. And we're going to go into this. The physician that's here and that will cover this topic, and we're going to cover it from A to Z, his name is Dr. Sukin Shah, and he's an interventional radiologist. He happens to be the section chief of this particular department at Newark Beth Israel Medical Center. Dr. Shah, welcome to our show.
Thank you, Dr. Bay.
All righty. I'm so glad that you could take the time out of your busy schedule and come over and talk to us about this topic. Now, this topic, and it's called, and it's a mouthful here, uterine fibroid embolization, right? Mm-hmm. All righty. But before we get into the main topic, I just want to understand, what is an interventional radiologist?
So I'm glad you asked that question because that's something that actually we have a hard time explaining to a lot of our patients. Most of the patients are familiar with radiology and what radiology involves, CAT scans, MRIs, ultrasound examinations, maybe x-rays. What we do is we take it actually one step further, and we use all of that imaging to provide imaging guidance for minimally invasive procedures.
Okay.
And so the advantage of what we do is that actually, because we use this imaging, we can do procedures through catheters oftentimes.
Oh, all right.
And the advantage of that is that patients could perhaps avoid major surgery. And so a lot of times what I like to say, interventional radiology is cutting edge technology without the cutting.
Oh, without the cutting. Now, when you say minimal, you really mean that they really don't need to go to the operating room? That's what you're saying?
Correct, exactly. So, whereas a patient who may go into a surgical procedure,
Right.
they oftentimes have general anesthesia, which has its own risks.
Now, when you say general anesthesia, that's when they're really
That's
asleep,
exactly.
really
That's
asleep.
when
That's when the tube is down the mouth and we're breathing for you, all of that stuff.
Exactly.
Okay.
So they are completely out. There's a breathing tube. It has more risks of anesthesia compared to the procedures we do, because they are minimally invasive. What we're actually able to do is actually still give sedation and keep the patient comfortable and sleeping,
Right.
but without the having to place a breathing tube down. And a lot of times we can actually do procedures under local anesthetic, just like if you went to the dentist and had some lidocaine. The advantage of that is that patients heal faster, they're able to go home much faster, and really don't have the risks of the anesthesia.
Right. Now, most of you actually work in the hospital, right?
Correct.
Where in the hospital are these procedures done?
So we have in our section, in interventional radiology, we have our own separate outpatient office.
So it's in X-ray somewhere?
It's in X-ray, it's radiology.
Okay.
Yeah, it's a branch of radiology.
Okay, alrighty.
Yeah.
And you have all types of, I'm assuming you have all type of machines. Now these machines enable you to do what? Kind of look into the body and see what's going on?
Exactly.
So you know where your little catheter is going? Is that it?
Exactly. So the advantage we have is basically we can see inside the body. We can detect things as small as 5 millimeters, which is basically kind of about that big.
Right.
But so the advantage is that because we can see, we don't necessarily have to, the procedure doesn't have to be as big, because we can target our approach.
Right.
And it's sort of minimally invasive targeted therapy for whatever that specific problem is.
Okay, all right. Tell me some of the diseases that you're able to help and how you're able to help those patients. I know for things like cancer, you may be able to do certain things to help them, like either take off fluid, or how do you help patients with the different types of diseases? Tell me about that.
That's a great question. So a lot of times what we can do is that, we can help patients with cancer.
Right.
And a lot of times, I'll give you an example, in someone, say, with colon cancer, that is spread to the liver. That's very common, can spread to the liver. In the past, what they might have had to do is give a bunch of chemotherapy, which would be given by another physician, and then maybe they might have had to undergo a surgery of the liver to maybe cut that tumor or cancer out of the liver.
Right.
But what we're able to do now is actually going in through the wrist, actually. We can actually snake a catheter down under image guidance all the way to the liver, and infuse the chemotherapy through the catheter directly at the site of the tumor. And the advantage is that they don't really have all those side effects. It works together with the other chemotherapy that's being given, and it's kind of like a 1-2 punch for the cancer.
So the chemotherapy actually goes right to the cells that are causing the problem?
Exactly. Because it's with the catheter and we're doing it under direct image guidance, we can actually just do it right at the site of the tumor. And that chemo that we give right at that site, there's less side effects because it's being given right in the liver. It's not going all over the body. Okay.
Now, most of the time when you're doing procedures, you're using the vessels. You're using what, the arteries or the veins? Do you use both of them? How do you get your catheters around?
Sure. We use both, actually. And oftentimes I say, the human body is just like plumbing, for lack of a better word.
Okay.
If there's a blood vessel, if there's blood going there, which blood goes everywhere in our body, then most of the time we can get to it. And the advantage is that, if we can get to it, most of the time we can do something to treat a problem there. Right.
Now tell me, I know so we're talking about the blood vessels. I know at times that blood vessels have clots in them, and I understand that you can help patients that have clots in their vessels as well. Is that a major, something you do often?
Yeah, it is actually. So, a lot of times patients with blood clots in their legs, it can cause a lot of pain and swelling in the leg. The leg may swell up because the blood clot's there. It can also be dangerous if that blood clot was to break off from the leg and then kind of travel up to the heart and lungs, and can cause some serious symptoms there. Pulmonary embolism, it's called, and you may have heard about it on the news. And it, has actually killed a lot of people. And so what we're able to do is actually go in, again, with a catheter, minimally invasively, and put a catheter in the leg and actually break up that blood clot and kind of suck it out of the vein. All of this, when the patient wakes up, they literally have a Band-Aid covering the incision. There's no surgical scar, no stitches, just a Band-Aid.
Oh, interesting, interesting. Now, I know that there are a lot of benefits to interventional radiology as opposed to surgery, obviously. And the one you talked about was that number one, you're not cutting the person. There's no big scar after your procedure. General anesthesia is not needed, so just a local little bit of sedation, and the patient is comfortable while the procedure is underway. And also, you go back to your normal activity most of the time. These are such great things that can occur. You got the procedure done, it's safe, and you went home afterwards. I love it.
Right. No, exactly. And while we do some procedures that do require general anesthesia, the vast majority don't, and so that's the advantage that patients have. They can come there in the morning as an outpatient. They can have their procedure done or their treatment administered for the cancer or for dialysis or whatever, and then they can go home.
Excellent. Excellent. Let's move on. Let's go to, I want to talk about uterine fibroid. Alrighty. Now this is, I know we're talking about embolization of this, but first just give me a little understanding of what a fibroid is.
Sure.
Number one, where is it?
Sure. The fibroids are, in the uterus, which, so women get them only, men don't get them.
Right.
And, you may have them and may not even know that you have them if it's small. So you don't necessarily have to have a problem with the fibroids. But what we have seen, especially in the African American population, is that they have a tendency to get more fibroids. And so what happens is they have more fibroids, the fibroids get bigger, and then once they get to a certain size, they can cause symptoms. And also, based on where in the uterus they are, it can also cause problems. So, if it's on the outside of the uterus, then what can happen is that it can cause, just by size, pressure, and kind of just squish things in and around it. For example, the uterus is in the pelvis. It's kind of responsible for, a woman's cycle. And if the fibroid gets big, it can kind of press on the bladder. So the women may feel like they have to keep going to the bathroom a lot. Or, they go and then they feel like they have to go again. And that's, a lot of times, that could be just from the fibroid pressing on the bladder. It can press on the colon. They may feel constipated from it. Or it can just press on the intestine in and around that area and cause problems.
So you can have, you stated something, you could have multiple fibroids? It just doesn't have to be one?
Sure. No, most of the patients that we see actually have a lot of fibroids. And when I say a lot, we're talking, on average, maybe 10 or 12 fibroids.
Oh, goodness.
And then some of those fibroids that are on the inside lining of the uterus, those are the ones that really cause problems with heavy bleeding during the cycle. And, we have women that come and see us and they're like, I wish I had known about this procedure earlier, because I've had these fibroids for about 10 years and I tried all these different things, and I didn't want to get the hysterectomy for the fibroids.
Okay. Now, if they're really small, will they do those usually cause symptoms, or the small ones usually you can get away without having to treat them?
So usually if the fibroids are small and not causing symptoms, there's no reason to treat it. It's usually, the procedure is really for patients that are having symptoms with their fibroids, whether it's, the bleeding, what we call the bleeding symptoms, or the bulk symptoms just from the size of the fibroids.
Okay.
So it's really for women who are having symptoms from their fibroids.
Okay. And what I understand and from my reading is that this is a benign, meaning it's not cancer?
Correct. So, right, the fibroids are not cancer,
Right.
and we check for all of that stuff ahead of time. So not every person that comes and sees us is actually a candidate for the procedure.
Okay.
If there's something that we look at, we do MRI examinations, ultrasound examinations to get a better look at the fibroids beforehand, and to determine whether or not that person is a good candidate for the procedure. There's a full screening process that goes in place to really see if that patient is a good candidate for it.
All right. Now, what I want to do is I want to get right to the meat of the subject and talk about uterine fibroid embolization itself. Just give me just an understanding of, they're big words, and just tell me about it a little more in detail, how you do it. You know what I mean?
Sure.
And will the patient be comfortable? Is there any pain? Things like that.
Sure. So, usually when somebody will come and see us in the office, oftentimes they've already had the imaging done. When I say imaging, either ultrasound or MRI. And so the advantage we have is, we kind of show them their pictures, and patients love that, because a lot of times a doctor will order a CAT scan or an MRI, but then they never actually get to see their pictures. They just go over to a report with them, and so the patients love it when we have a nice big screen. We show them their pictures, say, look, this is your uterus, these are your fibroids, and they're a lot of times they're surprised, like, wait, that's inside me?
Yeah. Now, when you're talking about CAT scan and MRI, let's get in. Talk a little bit about that. Okay. Now, a CAT scan, how does it actually show you the picture? Does it give you each individual organ? You can see them separately, or is it kind of meshed in and you got to explain it? Tell me about a CAT scan.
Yeah. So CAT scan and MRI are kind of similar in the sense that what they do is, there's kind of like a little tube, or what we call a gantry, and basically what the patient kind of lays on the bed, and then it just kind of slides in, and the machine takes pictures, and it takes pictures of everything inside the body, and so it's not just one organ or the other, it's basically the entire body. And so, for example, when we take pictures of the uterus, we can take a look at the ovaries as well, which is, right next to the uterus. It gets a look at the bladder and kind of everything in the pelvis. And so, sometimes we find that patients may have some other conditions as well, maybe a cyst in the ovary or something like that, in addition to the fibroids. And maybe the cyst in the ovary is causing their symptoms, not the fibroids.
Right.
And so it's very helpful to have that imaging to guide the appropriate treatment for that patient.
Okay, all righty. Well, what about as far as now take me through the procedure that you're talking about, this embolization. How does it happen? What do you do? First you bring the patient in, you give them a little sedation, then after that, what actually happens?
Sure. So once they have the initial consultation, we see that they're an appropriate candidate. They come in, it's an outpatient procedure, so they come in that morning. They get seen by our anesthesiologist.
Now, when you say an outpatient, it's not on the out on the sidewalk.
No. It's in the hospital, right? In our interventional suite, which is, again, a sterile environment, a sterile procedure room, and has all the, the sort of fancy imaging equipment there that we use to see inside the body. Right. And basically they come in, we do all the paperwork, they get put to sleep, and when I say put to sleep, it's conscious sedation, so it's kind of like a twilight sedation. So it's IV sedation, so they're monitored by anesthesia. It's very safe, but the advantage is that you don't have that sort of like hangover effect sometimes that you can get from general anesthesia, or that kind of irritation in the throat. You won't have any of that with this.
So they're actually breathing on their own. They're asleep.
Exactly.
They're sort of in a deep sleep, but they're breathing on their own. No tube in their mouth. No breathing machine. Nothing like that.
Exactly.
Excellent.
Right. So they're breathing on their own. They're fully monitored. And then what we do using ultrasound guidance, we actually do the procedure.
Ultrasound.
Yes.
All right. Explain ultrasound to me.
Sure. So ultrasound is just along with CAT scan and MRI. It's one of the other ways that we can see inside the body. It uses sound waves.
Like a dolphin uses sound waves.
Sonar,
it beeps out sonar, that type of thing, and it gives you a picture on the screen of what you're looking at.
Exactly, perfect. And so what we do is we find the artery here, and we basically numb the skin up, and we actually go in through the wrist. And then using the x-ray guidance, we actually take the catheter all the way up, and you can't feel this, it's inside you, patient sleeping. And then we kind of bring it all the way down into the pelvis. And then once we're there, we identify the uterine arteries, which are the blood vessels that supply the uterus. And we basically cut the blood supply to those fibroids off. And the way we do that is if you think of it as a garden hose or some big tube, we inject these small particles under guidance, and eventually you get enough particles that if you think of a garden hose and marbles, it eventually plugs it up, and then there's no more blood flow to those fibroids. And since the fibroids don't have any more blood flow, they shrink and die. And they kind of just shrink and go away. And so we always tell patients it's a more gradual process, meaning you may not see improvement that very first cycle after your procedure, but by the second and third cycle, you're definitely going to, you should feel better. We do a follow-up MRI, anywhere from 3 to 6 months out to make sure that things are progressing as they should be, and to check, make sure everything, that there's no, no new fibroids, that the fibroids we treated are completely, going away, etc. And, the women love it because, once the procedure's done, we put a Band-Aid on the wrist, and then they can get up literally within, a couple minutes of the procedure and walk to the bathroom if they had to.
Now, do you ever have to bring them back for a second treatment?
Sure. Good question. So a lot of times, women will want to know what happens if it doesn't work. I will tell you, in the probably 10, 11 years that I've been in practice, we've had to do that only one time. Part of it is you have to select the patients appropriately, and that's why a lot of times we'll do an MRI and we'll give them some X-ray dye or contrast and see what the blood flow is like ahead of time. So we know going in that the patient will respond and the patient is going to have a good outcome. If they don't have a good blood supply, we usually tell them, you're not a good candidate for this procedure. Hysterectomy may be the appropriate option for you.
So let me reiterate this a little bit. You're talking about the blood vessels and your catheters going to, actually getting to the uterus, and then you're letting these little spheres or little bubble-like plastic, or I don't know if they're gel-like or plastic, gel-like things that you plug up the artery, and no more blood is actually getting to the uterus, to that portion of the uterus.
To those fibroids,
to the fibroids, and the fibroids shrink down.
Excellent.
Now, how long does it usually take for them to shrink? And I mean, is it over like a month or two, or sometimes it can take 6 months, or you know what I mean, or in a couple weeks? Do you really?
Yeah, no. I mean, they start shrinking, right away, in the sense that once the blood supply is cut off, they can't grow anymore, and so what women will feel afterward in terms of the post-procedure symptoms. We always tell women that afterward it's still a procedure, and what you'll feel is that you'll kind of feel crampy abdominal pain in the lower pelvis, kind of like your period, but a little bit worse. And so that'll happen for a couple of days. You may feel like kind of low-grade fever, but we kind of know some of these symptoms are going to happen. So what we tell patients is, there's a very well defined pain regimen or pain medications that we give patients, and we say, take as prescribed to help control those symptoms. And those symptoms last about 3 to 4 days, but like I said, generally they peak about the second day, and by the 4th or 5th day, most women are just taking Tylenol, maybe Advil. We've had some women who have taken nothing, and by a week out, we do have some women who kind of return to work. In general, we tell women, take about 2 weeks. When you compare that, say, to a hysterectomy, you may be out anywhere from 6 to 8 weeks. You have a surgical scar. it's it's an actual surgery, so there's much more risk of damaging the intestines or the bowel or the bladder, etc. With the procedure that we do, those risks aren't there.
Right.
But the risks of our procedure can be the blood vessels could be damaged since we're working from the inside out.
Right.
But we kind of monitor that. We have very specialized wires and catheters that we use to do that. So really, it's great for women because you could potentially be back to work in a week or two,
right,
versus 6 to 8 weeks of recovery time. Also, risk-wise, if you look at the journals and the medical literature, the incidence of risks or complications are much, much lower with fibroid embolizations than they are with hysterectomy.
Okay. Is there a particular age that do better with the procedure than another age?
No, not necessarily, but most of the patients that we see are women in anywhere from probably the age of 35 to about 55. That's the bulk, but sometimes we've seen some women older than that and some women younger than that.
Right.
The other advantage is that at least with the fibroid embolization, you can still get to keep your uterus.
Right.
Especially if you're a younger woman who may potentially want to have children in the future.
Oh.
Now, obviously, there's no guarantee,
right,
but if you have a hysterectomy, then you probably won't have it, right? Because you won't have any uterus.
Right.
But at least with the fibroid embolization, you will at least have that option, although it's not guaranteed.
And I understand if you have fibroids, and if you have a lot of fibroids, it may be harder for you to get pregnant, number one.
Correct.
And if you do get pregnant, you may not be able to keep the baby. I mean, you may.
Correct, exactly. And so, we treat a fair number of women, probably in their mid to late 30s who do want to have kids, but because of fibroids, they've had some miscarriages, and so it's really from a personal view, it's a very satisfying procedure, for a physician to, in the way we can help patients.
All righty, excellent, excellent. Yeah. Well, I think we've covered it pretty good here. I think we've covered it from A to Z.
All right,
and we've just about run out of time, so I am so thankful that you were able to come over and give us the understanding of uterine fibroid embolization. It's still a mouthful, but I understand it now.
Right. No,
excellent, excellent. Well, thank you for coming.
Great, thank you so much for having me.
Excellent. Well, remember, knowledge is key. Action is power, okay? So let's come together and let's just help each other, guys. That's what it's all about. It's about taking action, using your power for something positive, and let's helping each other by caring and sharing. All righty? Remember, our website, www.obeyyourdoctor.com. Come and visit us. All right? Never institute any change in your medical care before you see your doctor. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace.